Good morning, good afternoon and good evening everyone, and a very warm welcome to the Global Public-Private Partnership for Handwashing's webinar in celebration of the World Health Organization's May 5th annual hand hygiene call to action for health workers, clean care is safer care. The PPPHW is a coalition of organisations from the public, private and academic sectors, all focused on improving global health and development through good hand washing. With Ebola putting hand hygiene in healthcare in the spotlight this year, and also talk of hygiene in the Sustainable Development Goals, this is a great time to take a closer look at hand hygiene in healthcare. We are delighted to bring you some fascinating speakers today. First, we have Benedetta Allegranzi, who leads the WHO's Hand Hygiene Initiative for Patient Safety, Clean Care is Safer Care, and also the Infection Prevention and Control Programme for WHO's Ebola response. She's going to tell us more about the global state of hand hygiene in healthcare, why it matters, and what WHO is doing about it. Next up, we're going to meet Cyrus Engineer, Director of the Healthcare Management Programme at Towson University and an adjunct professor at Johns Hopkins. He was most recently the country director for Johns Hopkins operations in Afghanistan, where he led a team of over 500 people evaluating the performance of health facilities. He's going to use his experiences in Afghanistan to discuss hand hygiene challenges in healthcare in post-conflict settings. Finally, we're delighted to have Robert Unger from the London School of Hygiene and Tropical Medicine. His work focuses on hygiene, behaviour-centred design and behaviour change. He's going to discuss the challenges in getting healthcare workers to wash their hands and provide some ideas of how to improve hand hygiene behaviour in health. We will conclude with a look at the opportunities for hand hygiene in healthcare in the SDGs and some small doable actions that mean you can start improving hand hygiene in your healthcare facility today. In terms of any technical things to know, if you would like to ask a question, we'll be mostly taking questions at the end, so please type into the little comment box that you can see on the right-hand side of your screen. If you cannot see that comment box, then look for a little orange arrow and click that and it should appear. And if you would like to live tweet, then the hashtag is SafeHands. So again, a very warm welcome. I hope you enjoy this session and I will hand you over to Benedetta Allegranzi from WHO.
Thank you very much, Hannah, and thank you so much to PPHW for hosting us today in such an important day, 5th of May 2015, the Hand Hygiene Day, and also the 10th anniversary of the Clean Care, Safer Care program that I have the privilege to lead at WHO. So as you can see in the first slide, this is just the introduction of the fact that this was launched as the first Global Patient Safety Challenge in 2005 by WHO, by the newly launched Patient Safety Program, which actually started in 2004. Next slide, please. As I said, this is the 10th anniversary this year, and as it was previously mentioned, the program started since the beginning as a program to reduce healthcare-associated infections worldwide, with a key focus on hand hygiene as the simplest and most effective act to reduce transmission of healthcare-associated pathogens from healthcare workers, from the environment to patients, and also from healthcare workers to healthcare workers as well in some cases. So it has started as a hand hygiene global initiative, but it has now become the infection control program at WHO, hosted in the WHO HQ Service Delivery and Safety Department. And we will see later that we have several more activities in addition to continuing to sustain hand hygiene improvement worldwide. Next slide, please. The three key objectives we started with and are still key to our program are the following. First of all, to raise awareness about the burden of healthcare-associated infections and engage with stakeholders at different levels to actually do these awareness raising activities worldwide. Second has been to mobilize nations and gather ministerial commitment to fight against healthcare-associated infections. And the third has been to develop technical guidelines and tools for primarily hand hygiene promotion and behavioral change in the field of hand hygiene improvement, but then also in other fields. So in terms of awareness raising, we have dedicated a substantial amount of time during the first period of our program to depict the global burden of HAIs, in particular the endemic burden, something that we considered, especially for developing countries, a neglected problem. And actually, you can see here, we published a report, a WHO report in 2011, and we also published other 2 papers, one in the Lancet and one in the WHO Bulletin, on this topic, and you can find data and further information in these publications. This was very useful to really sensitize healthcare workers, senior managers, ministries to tackle the issue of healthcare-associated infection. Next slide, please. Next slide. Thank you. So the second, as I said, has been the ministerial pledges as a sign, as a symbol of political commitment to achieve improvement in infection control. If you go to the next slide, we can see the map of now 137 countries committed to address healthcare-associated infections through the signature of this document. And I'm really pleased to announce that today Sierra Leone has signed in an official ceremony this document. And I can tell you, being the supervisor of IPC activities in Sierra Leone over the last 6 months, I can really witness that this signature corresponds to the real engagement of the government to improve infection control, infrastructures, knowledge and practices in the country. And if you go to the next slide, actually we can learn that this is exceptionally also dedicated to the memory of the fallen heroes of Sierra Leone health sector due to the Ebola virus. So this is particularly important, I believe, today. Next slide. The spread of these messages translate into practice in national campaigns that many of these countries have launched, and also activities at the facility level in many of these countries, and this is reflected in the images you can see in this slide about hand hygiene promotion worldwide in different languages with different images. Next slide, please. And if you can continue to click, thank you. This is to say that from country pledges, we started in 2009 to promote a global campaign on hand hygiene, because we have always been conscious that from the ministerial commitment, we need to reach the point of care in terms of healthcare workers' behavioral change and safer and cleaner care provided to each single patient. So if you can go to the next slide, we started to develop a strategy. Next slide, please. To reach, from the global level, to reach, if you can click on the slide, to reach the facility level and the point of care. Next slide. And we developed, according to the third objective, hand hygiene guidelines, and especially a point of care implementation strategy and tools to translate these guidelines and recommendations into practice. Next slide. We have developed this strategy, which is, as the scientific literature tells us since many years now, it is a multimodal strategy because bundles and multimodal approaches have been proven to be more effective in determining change of behavior and practices. And you can see here, we don't have time today, but there are different actions to be put in place in parallel to achieve hand hygiene improvement in the context of a patient safety climate that needs to be established in the institution and among healthcare workers and their leadership. Next slide, please. This was tested in several hospitals around the world. Therefore, this is a model which can be adapted and adopted in different contexts and in different resource settings, and it has now been implemented worldwide in many places. Next slide, please. If you can click on the slide, thank you very much. And go to the next. These are the 5 moments for hand hygiene, which we generated together with the strategy to help healthcare workers to identify the right moments for hand hygiene during healthcare. And you can see here the adaptation to the care for a patient with urinary catheter, which we issued last year. Next slide. And this year we are issuing 3 new posters with the same concept of hand hygiene embedded within clinical procedures, especially the risky clinical procedures which may entail transmission of pathogens to the patient through healthcare workers' hands. So hand hygiene for patients with central venous catheter, peripheral venous catheter, and if you go to the next slide, endotracheal tube. These are the new posters that we launched today on 5th of May 2015. Next slide, please. And this is the map of all healthcare facilities included in our global campaign. Nowadays, there are almost 18,000 facilities which registered officially. There are many more which are following our approach, adapting it, and making any possible effort to improve hand hygiene. If you can go to the next slide. Our program today has evolved, as I said. It covers many other areas, including the response, the IPC response for the Ebola outbreak, country support to implement the core components of IPC programs, still some work on establishing the burden of HAIs worldwide, with particular focus on SSI because they were found to be the most frequent type of infections. If you can go to the next slide. Indeed, you can see that we are developing SSI prevention guidelines. We are implementing a surgical unit-based program in some African hospitals in collaboration with the Hopkins University. And we are also focusing on injection safety and on antimicrobial resistance and infection prevention and control. Next slide. To go back to hand hygiene and the day of today, our slogan today is hand hygiene is the entrance door to strengthening healthcare systems and delivery. Next slide. The reason is, as an example, the fact that hand hygiene can reduce the transmission by multi-drug resistant organisms and also the infections that these organisms can cause. And last year we focused 5th of May on this particular topic, undertook a systematic literature review, the results of which you can find on our website. And if you go to the next slide, you can see that most of the papers that we identified, in particular 39, which had hand hygiene as the key intervention implemented, and MDROs as the outcome of these studies, most of these studies actually demonstrated an impact in terms of reduction of infection and or transmission rates. And many other studies, which include hand hygiene as part of a more comprehensive intervention, demonstrated the same, the reduction of MDRO infections. Next slide, please. This is why we continue to promote hand hygiene. This year, we focused on a social marketing strategy, which includes using the hashtag #SafeHands, and you can find on social media a lot of activity today and in the previous days based on this. Next slide, please. And many people have actually, if you can go through now the following slides, these are only images. Many people have used this to show their commitment or their request for safe hands as patients. Thank you very much, and there are many hundreds more going on today. The second initiative is to promote a hand sanitizing relay Guinness World Record, starting from Hong Kong, from this Baptist hospital in Hong Kong, and now being done from today to the 5th of September in thousands of other hospitals you can go through. And this entails to make this chain of transmission of alcohol-based hand rubs among healthcare workers and get to from the start to the end of this relay. The next and last points that I would like to make, if you can go to the next slide, please, are related to the Ebola outbreak and the need for improving infrastructures for hand hygiene and for WASH in general worldwide. As we all know, the absence of IPC basic measures and infrastructures, both in the community and in healthcare, led to this unprecedented catastrophic situation of this outbreak. And in particular, the lack of access to safe water, proper hygiene, and poor sanitation contributed to the propagation of the virus, both the community and healthcare facilities. Next, please. And indeed, in the 3 countries, we have very worrying data about the poor coverage with water, in particular in rural areas. These data, for instance, in the first row relate to urban areas where you can find 92% in Guinea, around 60 in Liberia, but rural areas are much less covered. And you see that the access to improved sanitation is very, very poor in these countries. And this was, if you go to the next slide, also documented by the global report that WHO and UNICEF recently issued, showing, which covers 54 countries, which shows that 35% of facilities worldwide have no soap and water or hand rubs for hand hygiene. 38% of facilities have no water, 19% no sanitation, and 42% lack of a system for safe disposal of healthcare waste. If you can go to the next slide, I think I really would like to conclude with the concept that infection control is a comprehensive approach. Hand hygiene is not sufficient, and especially hand hygiene relies on, for instance, good quality water availability, and integrates with many other areas in infection control and WASH, which cover, for instance, waste management or excreta disposal and management, and other aspects. If you can go to the next slide. WHO is working within the organization in order to improve this. And going back to hand hygiene, for Ebola, we issued these new guidelines in December 2014, which once again promote alcohol-based hand rub and soap and water for optimal hand hygiene And I can conclude with a very reassuring picture showing that in the next slide, even during the epidemic, you can have promotion of local production of alcohol-based hand rub. This happened in Liberia in November 2014. Next slide, please. Therefore, I would like to invite you all to join us today and in the next days. Go to our website, please use the Safe Hands hashtag and other activities that we propose you. Thank you very much.
Thank you very much, Benedetta. That was a fantastic and really fascinating presentation that really gave us a feel for hand hygiene in global healthcare. And now let's go to Afghanistan to hear more about hand hygiene in post-conflict settings. I will hand you over to Cyrus Engineer.
Thank you. Thank you. In the interest of time, I might what you call skip a few slides and focus on key aspects. So please bear with me. Good morning, good afternoon, good evening. It's a pleasure to be part of this webinar. It actually brings back great memories. I was one of the members of Benedetta's Global Patient Safety Challenge team that led the planning and implementation of May 5th. Everything, especially the implementation piece. If you ever wondered why we picked this day, it is because we wanted you not to forget this day. And we wanted a day that would actually stick in your mind, all the people's minds. And so we thought hard and came up with what would be one of those days. The World TB Day is dedicated to Robert Koch. So we said, let's find out today that will stick in the minds of people. And so 5-5 came across just coincidentally as we were discussing one day over lunch. 5-5 represents not only WHO's 5 moments, and a lot of the 5 strategies built inside as the building blocks, but it also represents our hands, actually. Both the hands and hand hygiene. So we thought we'll stick with 5th May. The 5th month, the 5th day also coincides with our 2 hands. So just in case you're wondering how we came up with 5th May. Afghanistan, I thought, how did I get introduced to this? Actually, next slide, please. I was just invited to assess the country. I was part of the WHO team posted at Hopkins to set up their office, and one of the professors in international health said, Cyrus, since you're doing a lot on hand hygiene, there's what you call an outbreak of infection, and we've been charged to assess hospitals. So why don't you come down here and help us assess the state of the infrastructure? And that's where my journey began. What seemed to be a week's worth of time spent in Afghanistan turned into an opportunity for me to spend about 2 years. So I'll just get into what we did there. As the country director, we led the health systems assessment. So let me move on to the next slide and give you a little bit of perspective about the country. As you know, Afghanistan is landlocked on all sides. It has 34 provinces and the capital is Kabul. We all know about the situations. Next slide, please. Situation going on there. A lot of insecurity seems to be dominant. This is a map as of 2011. You see all the red areas as being parts of the country that is highly insecure. Orange and yellow is like mostly insecure. You see, most of the country seems to have an issue of insecurity. This was in 2011 when I was posted there. About 120,000 active troops, mostly on the south and southwest side of Afghanistan. Bordering countries are Pakistan, and a lot of infiltration of militants across from the borders. Next slide, please. So here's what you see, in terms of in terms of a little bit more information. About 31 million people, mostly mountainous regions, and you see a lot of white because it's at an elevation. A lot of ethnic groups, the Pashtuns, the Tajiks, Hazaras, and a lot of farming activity. About 80% of them are involved in farming. Now, yes, farming, but what kind of farming? Opium farming. A lot of the country does opium farming, and about a third of the GDP for Afghanistan as of 2005 was from what you call opium farming, and 89% of the world's opium is produced in Afghanistan. Next. In terms of why I was pretty excited to get into this is because, could you please hit the button one more time, because that's because the infant mortality rates were, and the maternal mortality rate was ridiculously high. And I felt these were ridiculously high until I saw previous figures. Can you click one more time, please? You know, in one of the districts, rural districts, the maternal mortality rate in 2002, based on a reproductive age maternal survey conducted by Hopkins, was 6,400. 6,400 women were dying of birth, you know, in this particular province. And this was like, got me really excited. Next slide, please. So primary care, we all should agree, is the backbone of any country. And so the focus for the country was primary care. So next slide, please. They came up with what you call the BPHS and EPHS schemes, which are standard programmatic offerings. The basic package of health services focuses on primary care. The essential package of health services focuses on standards for hospitals. So both the BPHS and EPHS were implemented in Afghanistan. And as Hopkins, next slide, please, our role was to be a third-party evaluator for how they were doing. There were standards for structure. Did they have basins? Did they have water? Did the hospitals have bed? Did they have infection control measures in place? We used a balanced scorecard approach where we tried to address different aspects of structure, process, and outcomes. Next slide. We assessed over 1,000 healthcare facilities, including about 100 hospitals. In terms of the hospitals, we assessed in 2012, 2013, there were 100 hospitals where we wanted to assess the infrastructure. There were district hospitals, provincial hospitals, regional hospitals, and Kabul hospitals, you know, in the order of what you call maturity. District hospitals were sort of the smaller hospital. Provincial the regional hospitals were provincial hospitals were larger, and so patients would be referred from the district to the provincial hospital. If they were still sicker, they'd go to the regional hospital, and then, of course, to the central hospitals in Kabul. Next slide, please. So we assess the hospital structure in terms of, when we talk about hand hygiene, we want to make sure that the systems are in place first. So there were a lot of questions in different domains. As I said, we used a balanced scorecard approach. We wanted to focus on client and communities' perceptions about the facilities, human resources, whether they had workforce shortages, whether they had different types of people. Physical capacity is where we focus on. Did they have beds? Did they have sinks? Did they have a blood bank? Did they have all those necessary equipment? And were they functioning? Quality of service provision was, did they have infection control committees? Did they have process measures in place to assure? And then did they have management systems and other ethics and values and functional indicators? So this was a balanced scorecard approach, and I'll focus mainly on domain C and domain D. Next, please. So the physical capacity was broken into 4 domains. We'll focus on C2, which is the infrastructure index. The infrastructure index included what you call elements, as I mentioned, about beds, about what you call functioning equipment, and so on. Were they able to transport patients, and did they have ambulances? Did they have a functioning blood bank? Did they have water, running water, and so on? So the next slide gives you some results. If you focus on infrastructure index, which is C2, which is highlighted in red, you can see, there's the upper benchmark, the lower benchmark, and then you have the district hospital medians, the provincial. You can see that they are still getting there. They seem to have all the infrastructure, but when you look at the functionality, Kabul hospitals seem to be faring very poorly. This is surprising given the fact that Kabul is the city capital and the Ministry of Public Health is right there. But a lot of hospitals in Kabul reported having equipment but not functional equipment. For instance, the labs or the X-rays were not working. They were, clinical guideline indices were not being followed. So essentially, what you see here is a high level of infrastructure, but not necessarily the level that we want in terms of functionality across most of the hospitals. Go ahead. Next slide, please. So in terms of the quality, we focused on universal precautions. As far as hand hygiene is concerned, we did what you call whether they had an enabling environment and also the quality of care, but I'll focus more on universal precautions. Go on, please. Next slide. I know this is a slide that's hard to read, but as you can see, they seem to have a lot of coverage in terms of there's an item that says basin with the water, soap, and soap available in all rooms. Less than half of the hospitals that were surveyed, on 40 or 45%, seem to have a basin and water source. So when we come to hand hygiene, I mean, how can you, okay, that just tells me my time's up. I'll just take a minute or two to wrap up. Essentially, a lot of hospitals don't even have the basic infrastructure that's needed or required to perform hand hygiene. So measurement is a distant dream as of now, even in hospitals. So when we focused on community health centers, and I don't have the time to present the data, there were a lot of community health centers or primary health care centers that did not have running water also. Some of the community health centers had running water, but in the winters, they could not even perform hand hygiene when I visited because the taps, the ice was frozen and the water was too cold, or there was no running water. So they used to adapt measures. They would have something referred to as a Bukhari. A Bukhari is a heating, or they use diesel or wood to sort of heat. They would put water, they would warm the water and dip their hands inside. So challenges, a lot of challenges. A lot of the region is mountainous, and so there's no way to supply trucks with water, water trucks, even to these places. Next slide, please. So essentially, we also looked at what operating rooms. A lot of operating rooms did not have elbow taps, and I had a couple of pictures that I wasn't allowed to share with you all for copyright and privacy reasons. But essentially, there were, Afghanistan has a long way to go, and I suspect this is the case in many resource-constrained settings. A lot of resource-constrained settings have issues of running water, of availability of soap, basins and towels, and so. But even so, as Benedetta mentioned, hand hygiene is key, is the entry step. Next slide, please. We've not been as successful as the global public-private partnership has been. They are educating the issue of diarrhea. Afghanistan has many agencies and NGOs, including MSH, the Aga Khan, who are focusing on schools and educating children. So a lot of hand hygiene is occurring outside. And it's interesting that when I went, one of the doctors told me that my daughter tells me that I should be washing hands in a hospital. So basically, it's a reverse process where the children are telling their parents, and a lot of down-to-up hand hygiene. One would suspect, or one would expect, that hand hygiene would occur, I mean, the message would flow from the health facilities to the community, but in this case, there's a community empowerment process that's actually feeding back messages to healthcare facilities. Next slide, please. So, to summarize, there's slow progress, especially in certain areas of hospitals, particularly surgical areas, have running water all the time, but of course they have certain challenges of no elbow taps. There is an awareness about the importance of hand hygiene given outbreaks, etc., and the awareness is on the rise thanks to campaigns like WHO and local campaigns, but the challenges continue to persist. There is little or no systematic measurement, and the promotion is dependent on funding. Most of the healthcare system is currently funded by NGOs. And the biggest challenge is there are limited resources and a lot to do. So again, hand hygiene is a priority, but not really the most important priority. Thank you. The last slide is, of course, the general challenges for the health system in case. Thank you so much for your time.
Thank you very much, Cyrus. We really appreciate that presentation. It's fascinating to see what's happening on the ground in a country like Afghanistan. And now to think more beyond the challenges of hand hygiene hardware that we've been hearing about, we also know that one of the huge problems in getting people to wash their hands is behaviour change, even when the infrastructure may be in place. So to address that more, I am delighted to introduce Robert Unger from London School of Hygiene and Tropical Medicine. Thank you, Robert.
Hello, everyone. I'm very glad to be here. Thanks for the invitation, and thanks to everybody for attending. We've had two brilliant presentations with rather different perspectives, one kind of like a global perspective to begin with, and then this really fascinating case study where, as Hannah was saying, particularly there are some sort of hardware difficulties. I want to change our focus slightly and start thinking about what it is this situation of hospital-associated infections present to the people who are on the front line, and that's nurses. And I'm going to shift perspective as well with respect to the kind of sort of country focus and think more about the developed country context where we have a lot more information about what sorts of behaviors are going on. And that's not to say that that's where we should focus our attention, because obviously the challenges and the problems are larger elsewhere, but this is just a way of focusing more on the knowledge that we've got about the constraints on the behavioral side. So I want to talk about nurses as the frontline healthcare workers of most interest, I think. If you think about what they have to do on a day-to-day basis, it's pretty challenging. And if you look at what nurses say themselves about their jobs, they definitely see themselves, and I don't think we should question this at all, as being a caring profession with you know, the interests of their patients uppermost in their minds. They do go through a lot of training, but they say, you know, it's not about the training, it's about what we can get done on a day-to-day basis. And as a caring profession, where with patients who are quite often dying on them, they have to undergo, you know, quite considerable psychological stresses. Next slide, please. These are just some of the ways in which they express their own perspective. If you look at the kinds of places where nurses hang out on the web, you can see things like this, where they talk about multiple traumas, a unit of ventilators, and patients trying to die on me all day. So what's your job about? You're taking care of a stapler all day. And they suggest that their requirements are to have the memory of an elephant, an angel's patience, a heart the size of a sun, eyes on the back of your head, et cetera, et cetera. You're not even allowed to stop to engage, to deal with your own bodily needs. So, as I say, it's a really fairly stressful situation, especially in units where they're caring for patients with you know, very extensive needs. And I think the kind of poster on the right-hand side is quite interesting, because it keeps talking about the different constraints and needs of performance during the day-to-day job, and you'll see that hand washing is kind of mixed in there. In fact, hand washing does get mixed in amongst a lot of different activities during a day when nurses are on the job. Okay, next slide, please. So we've seen the WHO 5 moments, and again, just to emphasize that even in a very resource-rich kind of environment like U.S. hospitals, it's sometimes the case that if you're going to comply with the sort of WHO suggestions about how often you should be doing hand hygiene, it can be something like 60 times an hour. That's obviously pretty difficult constraint to try to fulfill. And you can see as a consequence that average compliance rates are around 40%, and those figures would be lower with people like doctors. Next slide, please. So there have been lots and lots and lots of studies of the kinds of factors associated with hand hygiene compliance rates being higher or lower. So if we kind of try to summarize in a single slide, which is a bit difficult, but just for the purposes of this brief talk, we can break down what the literature suggests can reduce the level of hand hygiene compliance into a number of different kinds of factors. And I'll begin at the kind of larger scale institutional level. So hand hygiene compliance varies a lot by the different kinds of units. And again, that's a function of the sorts of tasks that nurses have to deal with, the kinds of patients that they're having to deal with, and so on. Job type is also associated with differences in hand hygiene compliance. I sort of mentioned that doctors have lower rates typically than nurses, and I think that's a fairly general finding. Understaffing is also an issue. So if there are fewer staff taking care of a given number of patients, obviously the rate of hand hygiene compliance goes down. That's probably a function of the fact that they're busier, and the priority given to hand hygiene compliance is not the highest thing. So if you're really busy, your hand hygiene compliance goes down. There's also reports by nurses of a perception, at least, of a lack of commitment to a safety climate in some of the institutions they work in. So if that's a perception, then also hand hygiene compliance is observed to be lower. And then there's a suite of factors which I call behavioral or situational. And these are, again, just focusing right in on the fact that, what's happening at the moment at which you're supposed to be washing or washing your hands or using alcohol hand rub. There are a lot of things which can get in the way of doing that, one of which is wearing gloves or protective gear of some kind. Maybe the dispenser that you need to use is not that in a convenient location. It's not very close by where you actually are at the moment. You may perceive the patient's needs at that moment as being requiring your immediate attention, so that you don't perceive yourself as having the time to stop and do hand hygiene compliance. And then there are these kinds of glosses that are, again, self-reports. Well, I forgot. Presumably that's because there's high cognitive load associated with the multiple different kinds of tasks that you're probably having to perform as a nurse at that moment. And we know that that nurses have to do a lot of multitasking. And then another kind of complaint is high workload or being too busy, which is, again, a reflection of the overall high workload. There can be very kind of sensorial or bodily factors associated with lower hand hygiene compliance. If you're having to do it 60 times an hour, things happen to your hands. They get dry or sticky depending on what kind of technology you're using, soap or alcohol hand rub, etc. And the cumulative impact of that can be really quite severe on your hands. And then there are a number of what I call psychological factors, and these are expressed as having a positive rather than negative influence on hand hygiene compliance. So perceiving oneself as a role model to others in the unit can lead to increased hand hygiene compliance. A perception that others expect you to wash your hands also leads to higher compliance. The belief that you can do it readily, which is called self-efficacy in psychological literature, it's also associated with increased compliance. And then there are a couple of factors which come from standard health psychological modeling, which are about whether you perceive yourself as being at risk of infection and the benefits to you of the fact of hand hygiene technologies. Do they actually work to protect you from infection? And finally, a fairly interesting result suggesting that if you've learned about hand washing at home when you were young, and that becomes a strong habit, then you're more likely to do it when you're at work as well. Next slide, please. So if you're a person working in the health system and you want to increase hand hygiene compliance, how do you do it? There are a lot of factors associated with relatively low hand hygiene compliance. How do we get around those? How do we try to promote hand hygiene compliance? Well, these are examples of a few of the kinds of things that people have tried. And I would have to say, as a behavior change person, and this may be leading me into somewhat controversial claims, but I think the level of insight into the behavioral problems associated with increasing hand hygiene compliance in healthcare settings is pretty low. And so we get things like, and these are just a few examples of things which could be replicated thousands and thousands of times. You get cute little posters that are trying to draw your attention, and then you get an explanation about the 8 different steps you have to go through to wash your hands properly. Or you get a poster that says, there are cute little viruses everywhere and bacteria that you need to worry about. And here are the things that you have to do to make sure that you don't participate in the transmission of these from person to person in your work environment. Cute little bugs don't necessarily promote a motivating environment for making sure that, given all of these constraints that I've been talking about, in the moment, are you actually going to wash your hands? And then there's another poster about, all the cost to the economy, or again, the 6 steps. I mean, if you're being told that you have to go through 6 or 8 steps to wash your hands properly, that's just going to lead you to believe that you're not capable of doing so, especially given in these kinds of contexts where nurses are constantly working. So could I next slide, please? So here's potentially, again, a controversial claim, but I think we need to start thinking about something besides posters, and we need to get a bit more innovative. I think that is happening. Next slide, please. So we get packages of intervention components, but again, if you look at them, they're still kind of based on this standard model of doing hand hygiene compliance properly, doing it because there are germs about. So asking a nurse to worry about her own health in many respects, when in fact they actually know that they're not going to get ill in most cases, because most days go to work and they come home and they're not ill. So this isn't really a motivating factor for most nurses to suggest that they're at risk of infection. And then there's a bunch of really cute videos which are going around social media using Gangnam Style. The hospital personnel are running around the hospital corridors to the beat of this very popular North Korean tune, washing their hands. But again, although it's very cute and fun, I doubt it's going to have much impact when it comes to the push and shove of finding time and finding the motivation to wash your hands many, many, many times an hour. So next slide, please. There are things which we know do work. The problem is that they tend to work rather briefly. One is that you can discuss people, and preferably not just through use of a poster like I'm showing here, but you can discuss people with their own kind of situation, the fact that they actually may have bugs on them and they need to take care of that situation. And the other thing which works is punishment, particularly peer level punishment or threats to your job. We know that works, but either that's not possible, or these kinds of pressures are kind of self-limiting, because you can't work in a context of fear forever. Next slide, please. So I think the reason that we have this, that we're constantly talking about and trying to promote hand hygiene, is because we haven't found a solution for it yet. And I think part of the reason can be this sort of analysis that the institutional factors are those which can lead to high long-term hand hygiene compliance. Instituting a culture of safety in a hospital is associated with higher hand hygiene compliance, but I don't think we're very good, at least the kinds of programs that get implemented are very good at actually changing that. That seems to be something which is intrinsic to the institution. Situational factors are typically associated with low compliance, but is everybody hearing me? I can't tell. Situational factors are associated with low compliance, but they're not really manipulable at scale because they are situational. They're very temporary. They're variable from situation to situation. So it's very difficult to try to institute a specific kind of intervention that's going to work across all these different things. those different kinds of situations. And finally, such psychological factors, at least the ones which have been addressed thus far, can be manipulated, but they typically have been shown to produce only temporary increases in hand hygiene compliance. So what we have is a situation excuse me, where we need to identify new, because we haven't seen a good solution thus far, relevant. Obviously, there may be other kinds of solutions which aren't going to work in the kinds of contexts that we're talking about. And manipulable factors, that is, things that we can change given the means that we've got in behavior change kinds of programs that produce sustained increases in hand hygiene compliance. And the sustainability is really the key problem. We do have a variety of means available to us, but they don't seem to work long term. Next slide, please. So at the London School, we've been developing an approach to behavior change called behavior-centered design, or BCD. And this is a pictorial model of the kind of factors that we think are potential determinants of behavior. And these are broad categories. And they're pictured in a particular way to show that they're kind of causal relationships to one another. So you can think about it as the biggest context of behavior within which behavior takes place is the physical environment. And the physical environment is associated also with biological factors and social factors. So the environment we break down into 3 different levels. And then within this kind of environmental context, you have a body and you have a brain, and your brain tells your body what to do, and so your behavior is kind of represented as a interaction between the body and the environment, a dynamic interaction, kind of pictorialized as this cloud of interaction. And there's 3 different kinds of behavior production within the brain, which we call executive, motivated, and reactive. These are different kinds of behavior production mechanisms, and executive control over behavior is associated with this kind of conscious decision making, which most people try to address their appeals to. The motivated brain is the one which gets you up in the morning and gets you to achieve goals, short-term goals like eating a meal or taking a bath to get clean, or finding a mate. And your reactive brain is this brain that produces the very, very quick reactions, automatic reactions in many cases, to environmental cues or stimuli. And that's quite often ignored in most sorts of behavior change campaigns. But you can see that the model is essentially one where we say there are various ways that the brain can produce behavior using the body, and the behavior is an interaction with the environment. It changes the environment in ways that might then lead to additional behavior change. And then there's this concept of a setting, which is a behavior setting, which encompasses environmental aspects, bodily aspects, and mental aspects, which you can think of as this moment where you're asking a nurse to do hand hygiene compliance. There are just all these situational factors that constrain as well the ability of somebody to engage in particular behavior. Next slide, please. So what we've done is kind of take the situation as I described it earlier, where there are a variety of factors which seem not to be relevant, or which are relevant but which we can't change, or which simply don't produce sustainable behavior change as far as we can tell, given the literature. So what things remain, using this kind of what we hope is a broader gloss over the kinds of things which can influence behavior. And I apologize again, this is a fairly complicated diagram, but these are the factors which can be associated with the different components of the BCD model. And if we try to analyze hand hygiene compliance from this perspective, what we suggest is that the different factors in red are essentially irrelevant, or not changeable, or not sustainable. And those are things like it's unlikely that a behavior change program is going to be able to influence the physical environment in hospitals. So the fact that there are objects and infrastructure and macrostructures associated with the institutions of hospitals, we simply can't make use of those kinds of factors in our behavior change campaigns. So those get excluded. And similarly for most of the aspects of a biological environment. What we can impact are the things that we've kind of highlighted in white. And we think those are the social environment within the hospital context, but at a particular level of complexity. So not with respect to personal relationships, and I'm sorry, I'm talking about the circle on the top left, relevant to the social environment. So we don't think we can think about manipulating social relationships, because those are these like friendships. They're just too variable. They're a function of these interpersonal chemistries. We can't work on institutions, again, as I said before, or organizational levels. We can only work really with respect to the particular networks, the groups which are in particular units. And similarly, I think we need to think about, on the other side of the diagram, things like identity, kinds of beliefs that nurses have, change those beliefs. And the final thing I want to highlight, I know that we're running out of time, is norms. So there are norms associated with the specific units that nurses work in, and we need to probably, if we can get our hands on and manipulate norms, we need to get new norms of, by modifying expectations of what's proper behavior with respect to hand hygiene compliance operating in the various units that nurses work in. And thanks very much.
Thank you very much for that really interesting perspective. Very much appreciate that. So in conclusion, we've heard a lot about the importance and the challenges of hand hygiene in healthcare. And of course, we know that the key times for hand washing with soap generally are after using the toilet before handling food. But let's just remind ourselves once more with this slide of the key 5 moments for hand hygiene specific to healthcare. And you can see there's a link for you to find all WHO's useful tools around hand hygiene in healthcare. So how can you make hand hygiene improvements happen in your healthcare facility? Next slide, please. It's important to assess your current situation and understand that achieving good hand hygiene is actually a continuum. So you're never going to be all terrible or absolutely perfect, or at least that's going to be quite rare. What you really need to do is to use assessment tools to understand where you are, and then figure out small actions you can take to move yourself closer and closer towards excellent hand hygiene. And you can see here that WHO has a free hand hygiene self-assessment framework that you can actually use to assess that, particularly in terms of infrastructure. Next slide, please. Once you have figured out where you are and what you are achieving in hand hygiene, then it's time to figure out which of your good practices can be reinforced and spread, which of your hand hygiene practices leave something to be desired and can feasibly be improved, particularly through incremental steps. Come up with feasible, logical steps. Set yourself mini targets for your improvements. You can, whether those are infrastructure or motivating health workers' behaviour or working on the hand hygiene culture of your organisation. Hand hygiene improvement is absolutely achievable in healthcare, no matter where you're starting from. In terms of making that global, one of the big opportunities at the moment is the Sustainable Development Goals. Hannah Woodburn, Deputy Director of Secretariat Director of the Public-Private Partnership for Hand Washing, will give us a very quick moment on just what we can do with hygiene in the Sustainable Development Goals.
Thank you,
Thank
Layla.
you, Hannah.
Thanks, Layla. Hi, everyone. My name is Hannah Woodburn. Like Layla said, I'm the Deputy Secretariat for the Global Public-Private Partnership for Hand Washing. As we look to the Sustainable Development Goals, which will be agreed to this year, there's a really big opportunity to include water, sanitation, and hygiene. Unfortunately, hygiene wasn't included in the Millennium Development Goals, and so we believe that it's really important that it's included in the Sustainable Development Goals. As Benedetta and Cyrus both noted, there's a lack of infrastructure in many locations where hygiene needs to be practiced, and ensuring that hand washing and hygiene is in the Sustainable Development Goals will help bring that to be more of a reality. You see here a recommendation around water, sanitation, and hygiene. What we think is really critical is that hygiene is measured at the indicator level, not just in households, but also in schools and healthcare facilities. And I think this webinar has highlighted why making sure that we actually measure the availability of hand hygiene facilities in healthcare settings is very important. The PPPHW has developed an advocacy toolkit to help implementers and others both learn about the Sustainable Development Goal process as well as learn about what they can do to be involved in helping to make sure that water, sanitation, and hygiene are included in the Sustainable Development Goals.
Thank you very much, Hannah. So I'm conscious that we are at the end of our time, but there are a couple of questions. So for those of you who have to run it right now, thank you so much for attending. For those of you who are able to wait for a couple more minutes, Hannah, can you give us a couple of questions that you've received?
Yeah, certainly. Jim Mann has requested that copies of the slides be made available. Thanks, Jim. We will make sure that slides are available. Also, we've recorded the webinar, and so that will be available online later today. Jim also had a question about the role of healthcare-acquired infections and how little progress has been made on those. And the question is for WHO about how does WHO hope to deal with the behavioral issues in developed countries? Better results in these countries would serve as better models for the underdeveloped countries, which I think is an interesting perspective. At this point, I'm going to actually turn it over to Rick Johnston, who I see is on. Rick, are you able to address this question about WHO's work on this?
Actually, I think Bernadette would be in a better position. I'm with the Joint Monitoring Program interested in tracking basic water sanitation, hygiene, and health facilities. But as the monitoring team, we're less involved with the interventions to improve these indicators. So, of course, we interface with those people, but I wouldn't, be the best person, especially regarding the more developed countries.
Sure. Okay, great. Thanks. Unfortunately, Benedetta had to run to another meeting. Jim, we'll follow up with her and send you an answer to your question. And then I'm just looking through the questions that we have received. Dr. Will Sawyer says, how about talking about our hand hygiene as a social norm? Which I think is a really great question. Layla, do you want to address that about the role of hand hygiene being made a social norm?
Yeah, I think that we've had some really interesting work, particularly with the Super AMA campaign, which has been reported in the scientific literature, really finding that various emotional motivators can play a key role in improving hand hygiene in the household setting. And I think that there's really lessons to be learned from that moving over towards the healthcare setting. It was found that social norms have a key role in increasing hand hygiene in households, and there's various different ways, of course, depending on what your setting is, of figuring out how to really achieve those social norms. And I guess in healthcare, we're really looking towards things like role modeling and really institutional norms to drive those social norms, and also thinking about affiliation. When we think about nurses, when we think about doctors, often these groups of people have a strong affiliation to their own profession, and as such, if we can really figure out how to make social norms embedded in the context of hand hygiene, then that could be really impactful. I think it goes beyond talking about it into really instilling it, and that needs to be developed for the specific setting. But I think that must be a real key target area. Bob, do you have anything to add on that?
I thought that was a brilliant answer, actually. Yeah, I would totally agree that one of the things which is going to lead to sustainable behavior change has got to be change in norms. And there are some very interesting, there's some interesting theories about how to change norms out there. I would particularly highlight the work of Christina Picchieri with respect to this. She has a really nice book coming out. And I agree that it's more about just talking about hand hygiene. And in fact, I think there is a lot of talk about hand hygiene already in hospital environments, but it isn't translating into behavior, and that's the focus that we always have to keep in mind. But otherwise, yeah, I totally agree with your answer.
I should also say that I possibly entirely forgot to introduce myself. I'm Layla McKay, the Secretariat Director of the Public-Private Partnership for Handwashing. Sorry about that. Belated. Are there any further questions, Hannah?
We have further questions, but I think we probably need to wrap up at this point. So we'll go through the questions and address those offline. And then, yeah, thank you all very much for attending our webinar. Like I said, a recording will be made available later.
Thank you all very much. Goodbye.